Okay, well, hi everybody. Welcome to today's Student-Led Journal Club. My name is Anne-Marie Parker. I'm a research associate on the Joplin campus of KCU. And today I am introducing student Dr. Nick Caruso. Student Dr. Nick Caruso graduated from the University of Missouri in 2015. During his undergraduate years, he volunteered in the Surgical Intensive Care Unit and a cancer research lab. After graduating, he worked as an emergency room scribe throughout the Kansas City area. Student Dr. Caruso is interested in critical care medicine, but is staying open-minded. He enjoys playing the drums, piano, and guitar, and a few of his musical influences are the Beatles, Nirvana, and Mac Miller. He can be found watching the Kansas City Chiefs with a plate of barbecue next to his family's miniature poodle, Junie, on Sundays in the fall. So with that, student Dr. Caruso, the floor is yours.
Hello, my name's Nick Caruso. I'm a first-year medical student here at KCU, and today I'm going to be talking about telemedicine in the ICU. And to start off, a little bit about myself. Last week we had spring break, and I was able to go to Winter Park and go skiing with my cousin. And there's Junie that Anne-Marie was just talking about. And one album I've been listening to lately, a little bit because he's in the news, is My Beautiful Dark Twisted Fantasy by Kanye West. I think it's generally considered his best work, and I think it's worth listening to. And I'm a huge Kansas City Chiefs fan, and as of yesterday, Devontae Adams, probably the top 2 wide receiver in the league, was signed to the Las Vegas Raiders. And with that, you know, between Patrick Mahomes and the Russell Wilson with the Broncos and Justin Herbert on the Chargers, our division, the AFC West, is going to be pretty exciting to watch this year. But enough about me, and let's talk about the ICU. So what is the ICU? An ICU is an organized system for the provision of care to critically ill patients that provides intensive and specialized medical and nursing care during a period of life-threatening organ system insufficiency. So what this means is it's the sickest patients in the hospital. And these are trauma patients, cardiac patients, neuro patients, stroke patients, and patients with all kinds of issues. And an ICU typically has 10 to 20 beds, and it's staffed by physicians called intensivists. Intensivists come from many different backgrounds, including internal medicine, emergency medicine, and anesthesiology. And what I'm talking about today is telemedicine in the ICU in a paper called Telemedicine Virtual ICU, Where Are We and Where Are We Going? Now, this is a narrative review summarizing Tele-ICU structure, operations, outcome, and costs. Evidence came from meta-analysis with secondary data from Cleveland Clinic's Tele-ICU experience. And so what our goal with Tele-ICU is improving the ICU. And how do we improve the ICU? What does that mean? The 2 things we'll mainly be talking about today are decreasing mortality and length of stay, but other ways we can improve the ICU is through decreasing medical complications, including sepsis and blood product use, such as giving someone a transfusion. You can also do prophylaxis, which is treating an issue before it becomes a major issue for things like ventilator-associated pneumonia or deep vein thrombosis. And something that I think is important, as someone who's studying to become the 3rd generation of physician in my family, I've seen my parents and uncles miss their fair share of holidays. So I think it's important if we can figure out how to give physicians a better quality of life, not just for their sake, but for their family's sake as well. And so a main issue with, or maybe not an issue, the reality is that you know, the reason you miss out on holidays and whatnot and everything is from staffing the ICU. And so staffing in the ICU, the ICU is traditionally staffed by intensivists from 7 a.m. to 7 p.m. And what that means is that there's a 12-hour gap in coverage. And that gap in coverage is done by an on-call physician from 7 p.m. to 7 a.m. And while that works most of the time, patients slip through the cracks and deteriorate in the ICU. So if we have patients deteriorating overnight, shouldn't we just put more intensivists in the ICU? I know personally, if my family member was in the ICU, I would want a physician at their bedside 24/7. And so we've tried that with 24/7 coverage of the ICU, and the results are a little controversial. The outcomes do not necessarily improve because we're talking about caring for patients that are slipping through the cracks. We have 10 to 20 patients in the ICU, but only one of them might need intervention overnight. So it doesn't really change things having a physician there 24/7. Plus, when you're having a physician there for 24 hours instead of 12, you're doubling the physician costs without better outcomes. And there's just a limited availability of intensivists. We don't have the manpower to staff ICUs 24/7 by physicians. So what do we do if we can't have intensivists in the ICU for 24 hours? So first we have to do a proof of concept. The ICU is the sickest patients in the hospital. It's very intensive and hands-on care. So before we tackle the ICU, we had to tackle cardiac care using telemedicine. And we use cardiac care with telemedicine as a proof of concept. So through cardiac telemedicine, we've been able to diagnose heart attacks with EKGs before they happen. This would be like an ambulance doing an EKG and then sending the EKG to the hospital. We've been able to control and assess devices like pacemakers and defibrillators long distance. So here's a defibrillator and it can attach through Bluetooth to an iPad or your tablet, and the physician can monitor and control your pacemaker from afar. And this is a pacemaker inside of a patient. And then also, which is trending towards ICU level patients, is we've been able to do consultation and triage for higher levels of care and cardiac higher level of care, meaning just more involved ICU type patients. And also, so we know that telemedicine ICU can work for cardiac complaints. We also know intensivists directing cardiac care decreases severity adjusted mortality. So the goal of Tele-ICUs to combine cardiac telemed, or not a goal, a proof of concept for Tele-ICUs. We combine cardiac telemedicine, and we know that cardiac outcomes improve with intensivists. So intensivist telemedicine should work. But ICU telemedicine isn't Bluetooth and devices in your body and computers. It's a little bit more involved. So we should look at, what does ICU telemedicine look like between hospitals? And so this is a hypothetical situation I made up, and ICU telemedicine is frequently described as a central hub with spokes on the wheel. So you'd have a large hospital like North Kansas City, and what they would do is they would provide overnight ICU coverage to a metropolitan type hospital such as Menorah. So that would be overnight, or for smaller hospitals like Mercy in Joplin or Coffeyville Regional Medical Center, you could even have Tele-ICU intensivists covering these ICUs on the weekend or constitutively all the time. And so we've talked about what kind of how it looks broadly in between hospitals, but what does it look like in the actual Tele-ICU and ICU? And so I have a video from Yale's Tele-ICU Center. And one thing to note is that this team in Yale can cover 56 patient beds, whereas an on-site physician can only cover the 10 to 20 beds that they're near. And so we'll watch this video.
The advantage of a Tele-ICU is that they simply turn on the audio-video system and they're at the patient's bedside.
So we'll see how the fluid bolus works. We'll give him a few minutes. If his blood pressure doesn't respond, then we'll give him a low-dose epinephrine IV push. Yeah, and he doesn't look like he's breathing real well, so can you call respiratory therapy to the bedside?
If we could grab the ambu bag and assist him with ventilation until respiratory gets his ventilator. Diana, great job. The ICU doctor's on their way, and we'll continue monitoring until he arrives.
I'm Dr. Jonathan Seiner. Welcome to the Inside Tele-ICU at Yale Medicine.
Hi, Robin. Just noticed the blood pressure was low, systolic of 50s in one of the patients in room 310 at the medical ICU at St. Raphael's campus.
Hi, I'm Robin Waddell. I'm a nurse practitioner here at Yale. I've been in the Tele-ICU since August 2015 when the program launched.
The Tele-ICU is a way of providing care remotely to critically ill patients using two-way audio, video, and remote monitoring of data. Really a second set of eyes and an added layer of protection for the patients. The Tele-ICU operates from 7 p.m. to 7 a.m.
The patients, the families, and the nurses can see me on a dashboard screen in the room, and we're able to communicate the plan and update the family as needed.
Core of the operations is a list right here, and this list has all the patients that we're monitoring in the ICUs at St. Raphael's campus, the emergency departments at the York Street St. Raphael's campus, as well as the medical surgical ICU down at Greenwich Hospital.
The current technology and build in the Tele-ICU allows us to care for 56 patients at present, but we could easily expand it to 120 patients.
Can we check in with the nurse and turn on the display?
This is Robin, the nurse practitioner with Insight. Can I turn the camera on?
Yes, this is Diana.
Okay, good.
Systolic still in the 50s. In the old days, you would review your trend of your vital signs, and it might have happened an hour ago.
Tele-ICU looks at all the data available in the electronic medical record, as well as all the vital sign and other data coming in from the bedside monitors.
So their oxygen level, their blood pressure, their heart rate, their respiratory rate, as well as the cardiac rhythm from the electrocardiogram. The way the scale works, a big change in blood pressure would bump the patient way up to the top of the list immediately, and they go from a green to a red right away.
If they see any change in a vital sign, they immediately notify you.
Mobile Heartbeat is an app on the phone that is secure. So we're able to communicate about patients,
Come back from the emergency.
and they're able to contact us. We carry the phones all the time. Dr. Bernard's arrived to put the central line in.
We'll keep the camera on, and so if there's any management that you need help with while you're doing the procedure.
Just for a recap, we're bagging him and we'll place him back on the ventilator. If you need anything else from us, just let us know. We're available. I'm gonna camera out.
And so that's kind of a more boots on the ground view of what's going on in the Tele-ICU. And so I think it's best to kind of map it out and see what systems are we working with in the Tele-ICU. So first and foremost, something we have to look at is information management. And so this is security and data encryption, making sure that our patient's information is confidential. We're sending video over the internet that at times is going to be very invasive, and we want to be HIPAA compliant and make sure there's no loose ends. And we keep track of the data encryption. And then starting in the patient room, there's an in-ceiling camera and microphone, and then there's an integrated audio-visual TV, which allows the patient to see the Tele-ICU team from miles away. And along with the patient and nurses in the room, there's ICU patient support devices such as ventilators, infusion devices, dialysis, blood pressure machines, heart rate monitors, pulse ox, which measure the oxygen levels of blood. And so all of that is fed into the Tele-ICU. And the Tele-ICU contains those bedside monitors of the blood pressure, the heart rate, as well as contain electronic medical records, video conferencing, and image reviewers. It allows a communication between the patient's bedside as well as the central operations center, where there's the intensivist and then a staff of physician's assistants, nurse practitioners, and nurses, and they are using software which allows them to risk stratify every patient, as we saw in the video talked about. When a patient begins to deteriorate, it will bump that patient up to the top of the list, because this team is caring for 56 patients at a single time. But really, because we're trying to fill a gap, we're looking at the patients who slip through the cracks. Overnight, probably or hopefully 50 of the patients will be fine, but we're really just focusing on the 6 patients that deteriorate overnight. And because we're dealing with teams that are operating upwards of hundreds of miles away, using technology to communicate, we do take away a little bit of the art of medicine. We have to use best practices and research. We have to be a little algorithmic in the approach. The Tele-ICU intensivists have to be giving directions to the bedside, and it has to be consistent. So that's how we achieve quality, by staying consistent. And so now that we've looked at how all the systems interconnect, we should talk about what's the difference between the tele-intensivist and the on-call intensivist during Tele-ICU. The tele-intensivist is awake, algorithm assisted. They prioritize patient based on computer software. They can have eyes on the patient immediately. They have access to electronic medical records. Unfortunately, they cannot physically intervene. If in the middle of the night, the patient needs to be intubated, where you put a tube down the patient's throat to help and attach it to a ventilator to make them breathe, you can't do that from hundreds of miles away. So the on-call intensivist is still involved. And the on-call intensivist is asleep, as they should be, because the on-call intensivist has worked from 7 a.m. to 7 p.m. the day before. And they're more familiar with patients and staff. I'm sure we can all agree that there's always a barrier between Zoom and the real and being face-to-face, and they have to be there if necessary. So we've kind of established the framework of how Tele-ICU that is possible, but we have to ask, does Tele-ICU work? And to do that, we look at clinical outcomes. And the clinical outcomes that we've primarily looked at and what are most important is ICU mortality, ICU length of stay, hospital mortality, and hospital length of stay. And ICU mortality being are the patients dying in the ICU? And these are 4 meta-analyses that look at ICU mortality referenced in the paper. And you can see they all show a decrease in ICU mortality when telemedicine is involved. And now we can look at hospital mortality, which is generally significantly reduced, and significantly reduced. However, one study did find no significant change. Then ICU length of stay is significantly reduced in all studies, and hospital length of stay is significantly reduced. In 2 of the studies, however, it's also heterogeneous, where we don't always see a significant change in hospital length of stay. And something to consider, and while this data was being recorded on does Tele-ICU help or not, is that there's significant variability in Tele-ICU outcomes. And this is could be the subject of a whole nother presentation, but some ICUs utilizing telemedicine do way better than they were without. Some do about the same, and some do worse. And this is because there's various coverage models. Sometimes it's just used during the night or on weekends, or in smaller or in more rural places, it could be used 24/7. There's also different software. Some clinicians are very eager to use Tele-ICU, and so when that happens, they do better. If they don't, they do worse. As well as there's barriers to clinical privilege. And also at the same time, while these Tele-ICU studies were going on, we're just getting better at ICU care. We're better at sedation management, sepsis protocols, treating patients with blood infections, taking patients off ventilators, and we're also looking at other staffing scenarios that can work, including using physician assistants and nurse practitioners. So since we know that telemedicine can work, we have to ask, is it cost effective? The US healthcare system is cost constrained. Everything is about money at the end of the day. Everyone wishes everyone could get the best care all the time, but that's not always possible. So we have to see, does Tele-ICU make sense fiscally? And to look at the costs, Tele-ICU implementation is between $50,000 and $100,000 per bed in the first year. So when you think of an ICU with 10 to 20 beds, we're talking upwards of millions of dollars for hardware, installation, software, and staffing. There's also differences in cost per patient. Sometimes we find that using Tele-ICU decreases costs up to $3,000. Sometimes it increases costs. And so we're still in this area of a wild, wild west Tele-ICU because nothing is a constant. We're still figuring it out. And one good example of how these costs have changed significantly is, how do you code for ICU telemedicine when there is no code for ICU telemedicine? So coding is, it's like your bill that you get from staying at the hospital. They input codes and then the insurance companies reimburse it. In the early years of Tele-ICU, there was a code for intensivist physician orders fentanyl, and that would cost, and then the insurance company would reimburse it. But there was no code for telemedicine intensivist orders fentanyl. And so then insurance companies wouldn't reimburse the cost, but this has mostly been fixed in the past. However, it does affect the data when we look at costs in the past. And so since cost is an important part of implementing any intervention in healthcare, and today when we're talking about Tele-ICU, we have to look at an economic evaluation of telemedicine for patients in the ICU. So this is a study that focused on, they took real data points from the ICUs and their costs, and then they compared, then they did an economic evaluation, as well as doing an evaluation of with more variables in the ICU, figuring out, will this still be cost effective when things go wrong? And so to discuss cost effectiveness in economics, we have to define a few variables. Those variables include incremental cost, quality adjusted life years, incremental effect, and incremental cost effectiveness ratio. And first, let's talk about incremental cost. And incremental cost is the change in cost to treat a patient. The increase in which is the increase in cost of treating an ICU patient with telemedicine. Incremental cost includes equipment and depreciation, maintenance, software, and staffing. And what they found from the base case scenario is that incremental cost is $516 per patient, which $516 can seem like a drop in the bucket. And let's see what kind of benefit we got from using Tele-ICU. The way we look at the benefit of a medical intervention is something called quality adjusted life years. One quality adjusted life year is 1 year in perfect health. You're walking around, you run around, everything's great. And so the incremental effect measures the change in the quality adjusted life years with Tele-ICU implementation. The incremental effect was 0.011, which that doesn't make a lot of sense to most of us. So we have to make this incremental effect number make sense. And we do that through incremental cost effectiveness ratio. Incremental cost effectiveness ratio is the incremental cost over the incremental effect. What this is saying is, how much are we spending over how much health we're getting? And a widely accepted number is, if the incremental cost effectiveness ratio is less than $100,000, that means that this medical intervention, Tele-ICU, is worth doing. And so we should find out, is ICU telemedicine cost effective? And when you look at the incremental cost of $516 of 0.011 change in quality of life, we find that the incremental cost effectiveness ratio is $45,000. And if the ICER is under $100,000, it is cost effective. It is worth doing. And so we see here that telemedicine is worth in the ICU is worth doing. And we can take a further look at the numbers. So the numbers I was just talking about were from the base case analysis. The base case analysis was real data points that they used where they figured out what was the incremental cost per patient of $516, an incremental effect, which we found to be $45,000. But so that works with what we've done and what has happened in the past, but we also need a probabilistic analysis. The probabilistic analysis took the base case and added variables to it. It said, what if everything went wrong? Would ICU telemedicine still work? And what they found is that the incremental cost when everything was going wrong or right was $520. Similar change in incremental effect. Ultimately, what matters, the ICER was still over $100,000. So it means in the future, Tele-ICU should still work. And so we've shown that ICU telemedicine works. ICU telemedicine is cost effective. But do we want ICU telemedicine? It's kind of something I touched upon earlier, is that it's hard to adapt. It can cause, integrating telemedicine from hundreds of miles away. Do people like it? And so initially, the perception of tele-ICU can be negative. People believe it causes an increased workload. There's a burden of constantly monitoring patients, and you can get that conflict between staff at the bedside and tele-ICU staff. However, these concerns can be mitigated with effective communication and utilization patterns between teams. So what that means is if you're going to install ICU telemedicine, you sit down with both teams and you talk and you figure out what are the expectations, how is this going to work, what patterns can we use, how often are we checking patients. And as well as that, people do like the ICU. 80 to 100% of respondents thought telemedicine enhanced quality of care, and 60% of residents trained in ICUs with telemedicine desire to work in a tele-ICU post-residency. And so to bring everything we talked about together in a few key points, adoption of tele-ICU is increasing as part of our healthcare system. It's happening whether you like it or not, and people do like it once they can communicate and figure it out, and residents who train with it like it. Tele-ICU is associated with benefits including improved ICU mortality and decreased length of stay, despite a few instances where it doesn't. That's what we're working towards. We're making this better so it works everywhere. Tele-ICU is cost effective. However, implementation costs are still very high. We would have to get a place like Coffeyville Medical Center, like I talked about earlier, would have to create $1 million of funds just to put it there in the first place. So that's something to consider. And to talk about quality of life, when at the Cleveland Clinic Tele-ICU, they saw a decrease of 60% in overnight pages to on-call intensivists. So when intensivists are able to sleep through the night uninterrupted, they get improved quality of life. And when their life is improved, their family's life is improved. So, and all of this makes us say that continuing research into best practices of this of tele-ICU is prudent. And now I'd like to open it up to questions.
Dr. Steininger, I think you have a question.
Student Dr. Caruso, thank you so much for your presentation. You did an awesome job.
Thank you.
like the logistics of everything you did. It was a well-crafted presentation. So my question is this. You've been through most of the first year of medical school, some of it on pretty strict COVID lockdown, some of it less strict as we open up a little bit now. How do you think well, it's pretty obvious telemedicine is going to play a much bigger role moving forward. So my question is, has, in your view, COVID improved training for students in telemedicine potential? And what could KCU and other medical schools do to improve their telemedicine chops for students, if you will?
Mm-hmm. I believe that, through KCU, I've been able to figure out the hybrid, way of interacting with people. We had a, it's called a social determinant of health class, which is online. And today, and what we do is we go into breakout rooms and we talk with each other. And I think that what KCU has done is that by giving us opportunities to work in the hybrid and Zoom space, is that we get better at it. We learn to be more efficient. We're not afraid to communicate through chat and any means possible, which is how KCU has made me better prepared for telemedicine. And I think that other schools should utilize these hybrid and Zoom online discussions, because I think that it gives you an opportunity to work better with Zoom and be comfortable expressing yourself over the internet on a webcam. Because with the social determinant of health classes, it really makes you put yourself out there. I think today the chat was it honestly exploded, and people were very passionate about their opinions because we're talking about race and things that are close to all of our hearts. So I think if you can use Zoom to talk about some of the toughest discussions we have, that's going to make you all the more prepared to use Tele-ICU in the future, where you're going to have to speak with a patient about a life or death scenario.
It's not lost on me that here we are on Zoom doing a student-led case study and thinking about such things. So thank you again for a great presentation. Appreciate you.
Yeah. Thank you.
Just to echo that, I agree. Great presentation. Thank you for doing this with us. Does anybody else have any questions? Feel free to use the chat too if you don't want to unmute. Well, if not, thank you again. And thank you to everybody that joined us here. This is a weekly series now. It went from bi-weekly to weekly. So hopefully we'll see everybody here again next week. Thanks again, everybody that joined us. Have a good weekend, everyone. Thanks again, Student Dr. Caruso.
All right, thank you.